Welcome back to class, everyone. It's at this point in the semester, we're going to do a little bit of a pivot, and we're going to start talking about healthcare policy. I looked at the date of when this lecture is going to air. I'm currently pre-recording it, and it's currently today in my time in October, and I realized that by the time you're listening to this, we will have a new president. And so this is kind of a perfect time to start delving into healthcare policy, because presumably the new president is going to have some ideas about healthcare policy, and so it'd be good for everyone to have some background information on that. So we're going to be in chapter 15 today. The title of the chapter is The Health Policy Conundrum. And basically the idea of this chapter is I just want to demonstrate to you that it's really difficult to design a national healthcare policy. And specifically, it's hard to design one that functions well. So the reason it's really difficult to do this is because generally there are three things that we would like when we're thinking about designing a healthcare system. So the first thing we would like is we would like for the system to promote health. So we want the people who are covered by this plan to physically be in good shape, because the care that is provided is quality care that keeps people healthy. The second thing that we would kind of like to maintain is wealth. So we don't want the system to be so expensive that it's just kind of like sucking money out of people's pockets and leaving them broke. So we want to prevent that. We don't want it to be super costly. So we want wealth to still be maintained. And then the third thing we would like is we would like some degree of equity. So the idea is, ideally, we would like to have a healthcare policy where the healthcare that is being provided is not just taken advantage of by a particular elite group of citizens, but that everybody has access to the health care that's being provided. Okay, the reason I'm pointing out these three things in particular is because we would like health, we would like wealth, we would like equity, but simultaneously maximizing all three of those things is impossible because of trade-offs. So, for instance, suppose we have a policymaker who would like to have a healthcare system that maximizes health. So where do you get the best healthcare? Well, frequently the best healthcare is provided by private doctors who take private insurance. If you wanted to kind of get that for every person in the country so that they're as healthy as possible, well, you could promote health in that way, but if you do that, that's going to sacrifice equity, because those private doctors who are really good at caring for the patients aren't affordable for some people. And so when you push up the health, you're kind of pushing down the equity. Also, if we're concerned about equity, for example, so suppose we want some kind of healthcare system where the rich and the poor alike have equal access to good quality physicians. Well, one way that we might do that is we might provide insurance coverage that's publicly provided to low-income people. If we're going to do that, then we're going to have to increase taxes in order to finance that kind of a system. And so that's going to cut into wealth. And so no matter which bubble you try to enlarge, if you succeed in enlarging one bubble, another bubble is going to shrink because there are these perpetual trade-offs. So we have a name for this problem. We call it the health policy trilemma, because there are three things we would like: health, wealth, and equity, and we can't simultaneously maximize all three of those things. One thing that I'm just going to note here is that there's not a perfect way to design a national healthcare system. Different people have different preferences for which bubble they think is most important. So some people think health is the most important thing, and so they're willing to sacrifice wealth and equity to get health. Others think that equity is the most important thing, so they're willing to sacrifice health and wealth to get equity. And so depending on which political party you're a part of, or kind of what your ideology is, you're going to have different ideas in terms of what a good national healthcare system would look like. So what we're going to do now is we're going to think about how would one go about designing a national healthcare system. So in general, no matter what your ideology is, there are three broad questions that have to be answered when designing a national healthcare system. Question number one is, how should health insurance markets work? So health insurance, again, is this financing mechanism whereby people pay into a system, and then the insurance company provides reimbursement to the doctors when the person gets sick. So when we're thinking about healthcare or health insurance markets, we're particularly thinking about financing mechanisms. The second question that has to be considered when we're thinking about how to design a national healthcare system is how should moral hazard be controlled, and specifically in public insurance markets. Okay, recall what moral hazard is. Moral hazard is kind of like people doing dumb stuff that causes them to get injured more frequently, or people kind of inefficiently overutilizing healthcare when they're insured because they don't have to pay for it. And moral hazard in general, it just kind of results in this social loss where we're like burning extra dollars in healthcare that we don't need to burn those dollars, but it's like people are changing their behavior in a way that's inefficient. And so we're just kind of needlessly spending money. And that needless spending of money comes because people have insurance, and the insurance prompts them to do reckless things, or it prompts them to kind of order name brand medicines that are costly. So what a policymaker would need to think about is if there's going to be any kind of public insurance, so the government financing the healthcare, well, if the government doesn't want to like needlessly spend money because they're giving people insurance cards, and the government needs to think about what are mechanisms they can use to kind of stunt the growth in moral hazard. The third question that has to be answered when designing a national healthcare system is how should healthcare provider markets be regulated? Okay, healthcare provider markets are markets that consist of people who provide medical care. So these are the markets for doctors and hospitals and the actual deliverers of clinical care. Okay, there's going to be several options for how to answer each of these three questions. So I'm just going to kind of give you the gamut of options. Again, there's not one particular right way to do this. Different people have different preferences, but I'm just going to kind of explain to you the different options that are at a policymaker's disposal for answering these questions. So options for question one. So recall, what is question one? The first question a policymaker has to answer is how should health insurance markets work? Okay, one option is the policymaker could have a completely private insurance market. Okay, if there's a completely private insurance market, that means there is zero government provision of insurance. In other words, if a person wants insurance, they have to buy it on their own. So that's one option. A second option for a way to answer question one of how to do insurance markets is the policymaker could have universal public insurance. Okay, this is the opposite of completely private insurance. Universal public insurance means the government provides insurance for everyone. The way we see this is because it's public, therefore it's government provided, and it's universal, that means everybody gets it. So a universal public insurance policy would be consistent with a single payer insurance. Okay, the third option for how a policymaker might decide how to kind of do health insurance markets is they could promote compulsory insurance. Okay, compulsory insurance is basically just a requirement that people have insurance. It doesn't say whether the people have to have it from a private insurer or from a public insurer. They can get it from anywhere, but it's simply a mandate that people have health insurance. So just as a side note, compulsory insurance is one component of Obamacare. So Obamacare, or the ACA, had inside of it an individual mandate that said you have to buy health insurance. That was consistent with compulsory insurance. Option number 4 is a policymaker could sponsor or be supportive of employer-sponsored insurance. Okay, employer-sponsored insurance is basically a situation where the government requires employers to provide private health insurance to all their employees. So in the United States, we use employer-sponsored insurance a lot. Under Obamacare, there are certain regulations that businesses of particular sizes had to provide health insurance to their employees. As we'll talk about in subsequent chapters, the reason we have employer-sponsored insurance in the U.S. is kind of a fluke. It was because of some runaway inflation during World War II, and the policymakers made this weird kind of law, and businesses were trying to get out of the law, and in their attempt to get out of the law, they kind of prompted employer-sponsored insurance. So it was entirely unintentional, but it ended up sticking, And we use employer-sponsored insurance in the United States, and it's one way a policymaker could kind of regulate health insurance markets. The last way that a policymaker could do health insurance is they could set up a means-tested health insurance program. So means tested basically means that you are eligible for the thing, which in this case is insurance, based on your income level. So means tested health insurance would look like the government providing subsidized insurance coverage to the poor, and what constitutes poor is going to be based on a gradient, and it may also vary based on your geographic location. In the United States, we do have means tested health insurance. We call it Medicaid, and as we'll again talk about in a future chapter, the Medicaid system in the U.S. is kind of weird in that each state can do their own thing in terms of Medicaid. So technically, under law, a U.S. state does not have to offer its citizens Medicaid. They all currently do. And then technically, under law, each state can decide who they want to cover with Medicaid, so they can kind of set the threshold for what constitutes poor enough to be eligible. And then each state can also decide what they want to pay the doctors to reimburse care. They can decide what conditions they want to cover. And so it's just a patchwork quilt across the United States in terms of what the Medicaid programs look like. And again, Medicaid is an example of means-tested health insurance. Okay, so those are the ways a policymaker might answer the question, how should they have health insurance markets work? Again, the second question that a policymaker has to answer is how should moral hazard be controlled in public insurance markets if there's a public insurance market? Okay, there are 5 options for how to control moral hazard. Option number 1 is a policymaker could opt for cost effectiveness analysis. Okay, what is cost effectiveness analysis? We talked about this in a former chapter, but the idea is that cost effectiveness analysis helps us determine which treatments generate a higher return. And so cost effectiveness analysis from a policy perspective would mean that a policymaker would say that the public insurance only covers the types of treatments that are deemed to be cost effective or generate a high return. So what this would look like is the public insurance plan, the Medicare or Medicaid plan, would say, I'm not going to cover this treatment because we think it's too expensive for kind of the bang for the buck, but we will cover this other treatment because we think it's kind of worth it. I'm doing air quotes around worth it based on what the cost is. Option number 2 for how a policymaker might try to control moral hazard is they might impose cost sharing. So cost sharing is basically a tool where the cost of a medical bill is shared between the patient and the insurance company. So examples of cost sharing mechanisms are deductibles, co-pays, co-insurance rates. And as we talked about in the moral hazard chapter, the reason we have moral hazard is because people, they get insurance and they don't feel the sting of like making bad choices because they don't ever get stuck with a medical bill. So if you kind of take some of the sting and put it back into the lap of the patient, then they say, oh, you know, I better not jump off of cliffs. I better get like the responsible cast that doesn't cost millions of dollars. Because if I kind of change my behavior in an irresponsible way and I get stuck with a high medical bill, well, if there's a copayment, i.e. a cost sharing mechanism, then I'm actually going to feel a little bit of the pain of my bad decision. The third option is the policymaker could have gatekeeping. So this is the third blank under options for question number 2. Gatekeeping. Okay, what is gatekeeping? Gatekeeping is basically a barrier from patients to get to specialists without going through primary care doctors first. So, for example, in many insurance plans, if you want to go to a heart surgeon, you can't just like call up the heart surgeon and say, I'd like to schedule an appointment. You first have to go to your primary care physician, and then your primary care physician has to make a referral to the next guy who makes a referral to the next guy who makes a referral, and you move up the ladder to the heart surgeon. So there's a series of gates that you have to pass to get to the specialist, who is the super expensive doctor. So the way gatekeeping helps control moral hazard is it basically says we're going to start with the cheapest doctor first. You're going to have to see him. He's going to have to open the gate for the next doctor. And then if you need the specialist who's really expensive, you'll get to him, but we have to have preliminary doctors kind of verify your need for the expensive physician. So if gatekeeping is imposed in a public insurance plan, so if Medicare or Medicaid uses gatekeeping, then this could kind of help us reduce moral hazard and social loss. The fourth option is queuing. So queuing is basically a fancy way of saying standing in line. So the idea for how queuing might help us reduce moral hazard is if we, for example, limit the number of cardiologists that practice in the country, then if you want to go see a cardiologist and your primary care physician makes a referral, then you're going to have to stand in line and wait your turn to get to the doctor because there's a limited number of cardiologists. Okay, the reason this kind of helps with moral hazard is because people don't like to wait. So if I don't really need to see a cardiologist, I'm not going to stand in line and wait for one. However, if I need to see a cardiologist, I'll be willing to stick it out and stand in line. And so this process of standing in line or queuing, it filters out the people who don't actually need the care. And so we save some money here because the people who are just going to the doctor because they've got insurance and it covers it, they decide I'm not going to do that anymore because going to the doctor requires the time cost of standing in line. Okay, the final option for how a policymaker might control moral hazard is they might introduce prospective payments and DRGs. Okay, these are super interesting, so I'm going to spend just a couple minutes explaining these because if you're interested in healthcare policy in the U.S., this is super fascinating in my opinion. So, okay, what is a prospective payment? Okay, in almost all transactions in a normal economic market, payments are not prospective, they're retrospective. So in other words, you exchange the good, and then after you exchange the good, the consumer hands over the payment to the person who sold them the product. Okay, prospective payments means the person who's buying the thing pays up front, and then after they pay, they get the service. So the way this works in healthcare is we use a form of prospective payments called DRGs, which DRG stands for Diagnosis Related Groups. And the way it works is the following. So the government has created these things called diagnosis, or DRGs, Diagnosis Related Groups. And basically, they are groupings of people who have similar characteristics in terms of their demographics and their diagnoses. And then to each group, the government assigns an amount of money, and that amount of money represents how much it should cost a hospital to take care of a patient with those characteristics and that diagnosis. So for example, there's going to be one diagnosis related group that consists of 50-year-old males who have heart attacks, and maybe the government says for 50-year-old males who have heart attacks, the appropriate cost to care for that kind of person is $2,000. Okay, what that means is that if a 50-year-old male with a heart attack goes to the hospital, then the government, if this person is publicly insured, will pay that hospital the $2,000 that's attached to that DRG before the hospital does anything to the patient. And then the hospital gets those $2,000 prospectively from the government, and then they're free to spend those $2,000 using whatever kind of treatments they actually want. Okay, this is kind of interesting when you think about how this relates to typical payments. So currently in the United States, we use DRGs. What used to be the case in the United States is that we had normal retrospective payments. So what used to be true is that a 50-year-old male with a heart attack would go to the hospital. The hospital would do an EKG they'd write the price of the EKG on the slip of paper. The hospital would then do an x-ray. They write the price of an x-ray on the slip of paper. The hospital would decide the patient needed to stay in the hospital for 6 days. They'd write the charge for the hospital stay. And then the hospital just kind of tally up the charges for everything they're doing to the patient, add up the total charges, and then bill the insurance company that amount. DRGs prevent that. DRGs say, we don't care how much care you provide to the patient, because we know you kind of have an incentive to like provide more care than you need to, because you're going to get paid by the insurance company. So DRGs say, we're going to give you a fixed amount of money for this type of patient. No matter how much or how little care you provide to the patient, you're going to get that fixed amount of money. And so the way that helps kind of control moral hazard is because the hospital doesn't have an incentive to like give the patient name brand medications and give the patient fancy casts and like extra fluffy care just because they could potentially get paid by the insurance company. Now the hospital has an incentive to they actually have an incentive to like under provide care for the patient, because they're going to get a fixed $2,000, for example. And so the more the hospital can kind of reduce its costs in treating the patients, the more their profit margins are. Okay, so those are the options for how a policymaker who's designing a national healthcare system might address moral hazard. Okay, the third question that a policymaker has to think about is how should the healthcare provider markets be regulated? There's going to be basically 3 options for this. Option number 1 of how to like regulate physician markets is the government could have publicly provided healthcare. Okay, if healthcare, so the provision of care is publicly provided, that means it's provided by the government, then that means that the government is providing the country with doctors. They're providing the country with hospitals. And so as a result, the doctors in the country are all government employees. The hospitals are all government run. And so it's literally the government kind of like constructing the healthcare provision market and then hiring the doctors, like building the hospitals, and then the government just kind of runs that whole market. And so it's all publicly provided healthcare. Okay, the opposite of that would be we could have a private provision of healthcare. So private provision of healthcare means that the providers, the doctors and the hospitals, are privately employed and operated. And so if there's a savvy entrepreneur and he sees that a community doesn't have a hospital and he can make some money by building a hospital, he's free to just go and build a hospital there. Like that, this is like a very small regulation type setup. And so people can become doctors at will, they can be self-employed, and they aren't, the physicians aren't employees of the government, and the hospitals aren't owned by the government. The third kind of generic option for how healthcare provider markets might be regulated is the policymaker who's designing the national healthcare system might opt for private provision of healthcare. So this would mean the providers, the doctors, are privately employed, they're not government employees. But then on top of the private provision, the policymaker might have government set prices. So what this would look like is the government would say the price for an x-ray in this country is going to be $100, period. The price for an EKG is going to be $200, period. And then people are free to become doctors at will, and they're free to just kind of be their own employee. But when they charge their patients, they have to charge the patients the government set prices. And as we'll talk about, again, in an upcoming chapter, there's a good chunk of the world that actually uses this, where the provider markets, the physician markets, are privately operated, but the government tells them for every single service they provide what the price has to be. Okay, so kind of a framework for where we're going from here. There's essentially 3 kind of healthcare models that are used across the world. And so for the rest of this class, we're just going to compare different national healthcare systems so that you can see how different countries decide to do healthcare. So the 3 models that we're going to look at are, first of all, the Beveridge model. And then after that, we're going to look at something called the Bismarck model. And then the final model is the American model because there's no other country in the world that kind of does healthcare like the United States. So across the world, we have beverage model countries, we have Bismarck model countries, and we have America, which does healthcare in a very unique way. So we're going to just kind of split it apart and talk about it separately. So that's the game plan for the rest of the semester. Hopefully this will be super applicable to current events and future job prospects if you're thinking about going into healthcare or policymaking. So if you have questions about any of this, let me know in the next 10 minutes, and then after that we will meet back for the exercise. For the exercise today, we're going to do something a little bit different, and hopefully it'll be a little bit more fun than making you do normal, difficult, boring homework assignments. So today I'm going to have you read a New York Times piece. This article is a little bit old, but it does a good job of kind of setting the stage for where we're going. So in 2017, the New York Times published this kind of like a tournament between different countries of the world in terms of how good they were in healthcare. And to determine the winner of the tournament, they invited a whole bunch of health economists to weigh in. And so each round of the tournament put two countries head to head against each other. And then they asked the health economists, which country wins in this round. And so what I would like you to do for the exercise is to just read through the article. And then for each of the first rounds, I would like you to select the country that you would pick to win that round. There are not correct answers for this exercise. I just want you to start thinking about how you view healthcare policy and what your preferences are. So again, just for the first rounds of the tournament, state your winners. One thing I'll kind of throw out as fun facts as you're going through this is the bios of the people who are weighing in the New York Times tournament. So one of the tournament judges is a guy named Craig Garthwaite. He is an economist who I believe he's currently teaching economics at Northwestern, and he's a publisher for one of the big economics journals. So he's a super smart guy who's edits a journal. He's rejected a couple of my papers. They didn't make it into his journal, but like a good economist. One of the other tournament judges that they reference is Hugh Reinhardt. He's, again, like a super prolific healthcare economist, so if you ever run into his name, that's him. And then the two guys who wrote the article, who actually typed up the words for New York Times, are Aaron Carroll and Austin Fracht. If you have ever heard of The Incidental Economist, it's a blog that's pretty popular, and it just talks about health, economics stuff, and public policy. Aaron Carroll and Austin Fracht are the two guys who kind of head up that blog. So if you like the article, check out their blog. Kind of ironically, I got an email about a month ago from Austin Fracht, the guy, one of the authors for this New York Times article. He was going to write another piece for the New York Times on emergency room crowding, and he wanted to cite somebody. And so he sent me an email and said, I see you do research on ER. He's like, I would like to say that you said this. Can you say this? And so I got quoted by him telling me what he wanted me to say. But anyways, he's a cool guy too. So once you get done reading this article, that will be it. Hopefully this gives you some food for thought for the rest of the afternoon, and I will see you next class.